Hi everyone, welcome to the Heart Stuff That's Not CAD or ACS video. We're also going to be discussing some lung stuff later. Let's start with talking about hypertension or high blood pressure. Systolic pressure is the number measured when the heart squeezes, and diastolic pressure is the number measured when the heart relaxes. When written out, systolic is the top number and diastolic is the bottom number. Normal blood pressure is considered to be somewhere around 120/80, and hypertension is defined as pressure greater than 130/90. Pressures over 180/120 are considered to be a hypertensive emergency or a hypertensive crisis. It's completely normal for blood pressure to fluctuate throughout the day based on activity. For example, if I was to go out for a run, it will be totally normal for my blood pressure to rise above 120/80. The negative effects of hypertension are cumulative and can take years to manifest, but it is a strong contributing factor for developing various heart diseases such as cardiomyopathy, cardiomegaly, heart failure, and myocardial infarction. Hypertension also subjects the tiny blood vessels in your brain, kidneys, and eyes to higher pressures and can lead to strokes, kidney failure, and retinopathy. Hypertension is generally treated with antihypertensives or high blood pressure medications. There are several types of blood pressure medications that have different mechanisms of action. While you don't have to memorize them, it might be helpful to learn a little bit more about them. ACE inhibitors generally have the suffix pril and include medications like lisinopril, Acupril, Vasotec, and Altase. ACE inhibitors, as the name suggests, work by inhibiting ACE or the angiotensin converting enzyme. To better understand how ACE inhibitors work, we have to talk about the RAS or the renin-angiotensin-aldosterone system. The kidneys have the ability to monitor blood pressure, and when they sense a blood pressure that is lower than normal, they secrete an enzyme called renin. At the liver, renin converts the molecule angiotensinogen to angiotensin 1. Then at the lungs, angiotensin 1 is converted to angiotensin 2 by the angiotensin converting enzyme, or ACE. Angiotensin 2 works to cause systemic vasoconstriction as well as the adrenal glands to secrete the hormone aldosterone. Aldosterone works in the kidneys to retain more water, which leads to increased blood volume and ultimately increased blood pressure. So it's a bit convoluted, but basically RAS is a system that works to increase blood pressure. In hypertension, we want to lower blood pressure. So ACE inhibitors work by blocking the enzyme ACE. This leads to less angiotensin 2 and less aldosterone. This then leads to less systemic vasoconstriction and less water retention, which all lead to lower blood pressure. ARB, or angiotensin 2 receptor blockers, tend to end in sartan and include medications like losartan, valsartan, and Benicar. ARBs also act on the RAS to lower blood pressure, but unlike ACE inhibitors, they work by blocking the angiotensin 2 receptor. Again, less angiotensin 2 means less systemic vasoconstriction and less aldosterone, which means less water retention, lower blood volume, and ultimately lower blood pressure. Beta blockers usually end in lol and include metoprolol, atenolol, carvedilol, labetalol, and asmolol. Beta blockers work by blocking the effects of epinephrine on the cardiac muscle to decrease contractility of the heart or how hard the heart squeezes. Calcium channel blockers tend to end in dipene and include amlodipine, nicardipine, and nifedipine. Calcium channel blockers work by causing systemic vasodilation as well as by reducing the heart's contractility. Diuretics, which include furosemide or Lasix, spironolactone or aldactone, bumetanide or Bumex, and HCTZ or hydrochlorothiazide, lower blood pressure by lowering blood volume. It achieves this by increasing urine production at the kidneys. This is why diuretics may be referred to as water pills by patients, and this is also why patients generally don't like taking them as it causes an increase in urinary frequency. Here's a simplified diagram of a nephron, which is the functional unit of the kidneys. In addition to illustrating the movement of various ions and water at different parts of the nephron, it also shows how different diuretics act on different parts of the nephron. For example, Lasix act on the loop of the Henle, whereas HCTZ works on the distal convoluted tubule. Another treatment of hypertension is lifestyle changes. Losing weight, quitting tobacco use, decreasing sodium intake, and exercising regularly can all help in achieving lower blood pressure. When we see patients in the ED presenting with elevated blood pressure, it's important to document the names of their normal antihypertensives, dosages, and when the patient typically takes them. Also document when the patient last took their medications and whether or not they have been compliant. For example, if the patient usually takes lisinopril but hasn't taken them in over a week, it shouldn't really come as a surprise if they roll into the ED with a pressure of 180/120. Also, if they're having recent changes with their medication, be sure to include that in your documentation as well. So that's hypertension. Let's move on to CHF. CHF stands for congestive heart failure. Remember that the heart is essentially a pump that circulates blood throughout the body. When the heart is no longer able to pump as well as it used to due to heart disease such as cardiomyopathy, blood isn't circulated as well and it begins to become congested, kind of like a traffic jam. The thing with blood vessels is that they're not exactly waterproof and can actually be quite leaky. When blood flow becomes congested or backed up, fluid can leak out of the blood vessels and into the surrounding tissues, kind of like if there's a traffic jam on the freeway, cars will begin to exit to the side streets. This tends to happen the most around the lungs, lower extremities, and in the abdomen. Normally, the ROS is a great system that works to increase blood pressure when low pressure is detected. But in CHF, the ROS actually works against you. CHF patients and their failing hearts may not be able to pump well enough to maintain a normal blood pressure. When this is detected by the kidneys, ROS gets kicked into effect. Renin gets released, which again leads to angiotensin II and an aldosterone. All of this works to increase blood volume in an attempt to increase blood pressure. Going back to the traffic jam analogy, this is like adding more cars when there's already a traffic jam. When fluid builds up in the lungs, gas exchange at the alveoli becomes diminished. This causes patients to be short of breath, which is the most common chief complaint of CHF exacerbation. Patients may also complain of worsened dyspnea on exertion and orthopnea, having to sleep propped up on multiple pillows or sleeping sitting up in a chair. They may also complain of generalized weakness, fatigue, and peripheral edema as well as chest pain. Let's talk about some of the physical exam findings that a patient with CHF may exhibit. The patient may appear to be dyspneic, meaning they seem to have a difficult time breathing. Auscultating or listening to the lungs, you may hear rales or crackles, which is due to fluid buildup in the alveoli. The patient may be exhibiting JVD or jugular vein distension. Due to congestion, blood that's draining from the head cannot enter the right atrium and gets backed up at the jugular veins. The patient may be tachycardic. When a patient has heart failure and the heart isn't pumping very well, it has to beat faster to compensate for the decreased stroke volume in order to maintain its cardiac output. Patients may also be diaphoretic and have a pallor appearance. One of the most common physical exam findings will be edema in the lower extremities, severe enough that the patient has pitting edema. So that's physical exam findings on a patient with CHF. Let's talk about other ways we can make the diagnosis for CHF. A lab test that can point us towards CHF is called the BNP, which stands for brain natriuretic peptide or B-type natriuretic peptide. It's a hormone that was first discovered in the brain, hence its name, but it's actually produced by the myocytes in the heart. BNP is normally released in response to the heart becoming stretched out when blood volume is increased, such as in CHF when patients are fluid overloaded. As the name suggests, it's a natriuretic, so it causes increased urine production at the kidneys to lower blood volume. Normal BNP is about 100, but in CHF patients you can see BNP in several hundreds and even several thousands. On chest x-ray, pulmonary edema and/or pulmonary effusion will be seen. Pulmonary edema can be thought as fluid inside the lungs, and pulmonary effusion can be thought as fluid around the lungs. So the x-ray on the left is a normal chest x-ray, and the x-ray on the right is showing pretty significant pulmonary effusion and edema. You can see how the lung fields are much more fluffy, which is due to all the fluid that's inside the lungs. So fluffy is pulmonary edema, and one of the easier ways to look for pulmonary effusion or fluid around the lungs is by looking at the costophrenic angles. That's these sharp areas at the base of the lungs. Since the patients are generally sitting upright when a chest x-ray is taken, the fluid around the lungs will pool at the bottom, blunting the costophrenic angles. In this particular example, you pretty much can't see anything on the left lower side. One last thing I want to point out is the enlarged heart or cardiomegaly that's seen on the chest x-ray. Look how big it is. So again, shortness of breath is the most common chief complaint of CHF, but there are tons of other diseases and illnesses that could be causing shortness of breath. So it's important to rule out things like COPD, pneumonia, pulmonary embolism, a myocardial infarction, or cirrhosis. One of the best tests to evaluate heart function is an echocardiogram, which uses ultrasounds to visualize the heart. A TEE, or transesophageal echo, is the preferred method as the ultrasound probe is inserted down the esophagus to visualize the heart from the posterior aspect where the sternum is not in the way. Using the echo, we can measure the patient's EF or ejection fraction, which is a percentage of how much blood the left ventricle pumps out with each contraction. 50 to 70% EF is considered normal, and EF below 40% is considered to be heart failure. So we probably won't be curing anyone of their CHF in the ED, so the treatment focuses on symptomatic relief and addressing anything that may have caused a CHF exacerbation. Medications commonly given for CHF are Lasix and nitroglycerin. Let's take a second to think about how Lasix and nitroglycerin can help in treating CHF. Lasix, as we talked about before, is a diuretic. It increases urine production and decreases blood volume. Nitroglycerin is a vasodilator. It allows the blood vessels to become relaxed and dilated so that more blood can flow through. Using the traffic jam analogy again, Lasix is like removing the number of cars that are on the road, and nitroglycerin is like widening a 2-lane road to a 6-lane freeway. The general idea is that we remove excess fluid off the patient so that their lungs will be able to function better. By the way, if a CHF patient also had CAD or ESRD, how would this make treating their CHF exacerbation more difficult? It's because diuretics work on the kidneys. If a patient has kidney disease and their kidneys aren't working very well, it will be much harder to remove the excess fluid off of the patient. Something else we can try for CHF patients is BiPAP, which stands for bilateral positive airway pressure. It's a respiratory ventilator which allows more air to get in and out of the lungs. Although the ED primarily focuses on symptomatic treatment, there are some additional treatments for CHF that can be done outside of the ED, including a defibrillator, LVAD, and a heart transplant. A defibrillator can shock the heart back into rhythm if it were to stop. An LVAD or left ventricle assist device is a mechanical pump that can help the heart in pumping blood throughout the body. It's typically a temporary measure that can last a few years until the patient can receive a heart transplant, replacing the diseased heart with a new one. Now that you know a little bit more about CHF, you may be able to recognize these patients when they come into the ED. Important things to document will be their medications, especially their diuretics, recent medication changes, medication compliance, the patient's cardiologist, and recent cardiac studies such as an echocardiogram. On Cerner, you can find the details of an echocardiogram by going into Notes, Diagnostic Non-RAD, Cardiology, and looking for the echocardiogram. Feel free to read through the echo report and document the EF as well as any other significant findings. If the patient has a pacemaker or an AICD, you may be able to find details under Notes, Procedures, and looking for the pacemaker or AICD implantation note. It can be very helpful to know the maker of the pacemaker or defibrillator, such as Boston Scientific, Medtronic, or St. Jude. So that about wraps up CHF. Let's move on to PE or pulmonary embolism. So a pulmonary embolism is when a blood clot becomes stuck in the pulmonary arteries. Typically, these blood clots originate from the legs as a DVT and moves up to the lungs. To clarify some terms, a thrombus is a blood clot, and an embolus is anything that moves until it gets to a blood vessel that's too small for it to pass and gets stuck. You can have a fat embolus, a septic embolus, or an air embolus, amongst many other types. A thromboembolus, or a piece of a blood clot that breaks off and becomes mobile, is typically what we see in a pulmonary embolism. Let's review the flow of blood through the heart. Venous blood enters the heart into the right atrium via the superior and inferior vena cava. It then gets pumped to the right ventricle, which pumps the blood through the pulmonary arteries and into the lungs. At the lungs, CO2 is dropped off and O2 is picked up. The oxygen-rich blood is returned to the heart via the pulmonary veins and enters the left atrium. It then gets pumped to the left ventricle, which pumps the oxygen-rich blood through the aorta and delivers it throughout the body. Then the cycle repeats again with every heartbeat. Let's say a patient has a DVT in their leg. A piece of it breaks off and goes up to the heart. It will first flow into the right atrium, then the right ventricle, through the pulmonary arteries and into the lungs. This is where it eventually gets stuck and becomes a pulmonary embolism. The embolus will obstruct blood distal to its location, which means blood won't be able to drop off CO2 and pick up O2. So patients will complain of things like shortness of breath, chest pain that is worse with deep breaths, and may be found to be hypoxic with low oxygen saturations. Patients may also complain of hemoptysis and may have symptoms of a DVT, such as leg pain, redness, and swelling. By the way, DVTs typically occur in just one leg. It's pretty rare for someone to have DVT in both of their legs. Here's why we make a big deal about PEs. It's the second highest cause of sudden and unexpected death, only beaten out by heart attacks. It's the third most common cause of death in vascular disease, only following heart attacks and strokes. 60% of those that die in the hospital will have had a PE, and it's one of the most commonly missed fatal diagnoses, about 70% of them going undiagnosed until they're found on an autopsy. That's why PE is always on the differential when a patient comes into the ED complaining of chest pain or shortness of breath. Let's move on to how we can look for these things. Just like every other chest pain and shortness of breath complaint, an EKG and a chest x-ray will be performed to rule out other causes of the patient's symptoms. If a DVT is suspected, an ultrasound of the lower extremities will be performed. Veins are normally compressible because they have a much lower pressure than arteries. But when there's a blood clot within the vein may not be compressible and the clot may even be visible. In addition to unilateral pain, swelling, and redness of the lower extremity, another physical exam finding of a DVT is called a Hohmann sign. This is where dorsiflexion will elicit calf pain. By the way, there are certain changes that may be picked up on the EKG and chest x-ray of patients with a pulmonary embolism, known as S1Q3T3 and the Hampton sign and the Westermarck sign respectively. But they're not always present even in patients with a PE, and they can be super subtle and easily missed. So the absolutely best way of diagnosing a PE is with a CT angiogram of the chest, which is a CT scan of the chest where contrast dye is utilized to visualize the pulmonary arteries. So here we have a CT scan where the contrast dye shows up as being white, and we can see the pulmonary artery branching off to the right and the left. The gray thing pointed out by the red arrows is a pulmonary embolism. This particular example is of a saddle embolism since it's affecting both the right and the left pulmonary arteries, kind of like a horse's saddle. So while the CTA is a fantastic tool allowing us to visualize the pulmonary arteries and the pulmonary embolism, it also exposes the patient to quite a bit of radiation. Also, contrast dye is toxic to the kidneys, so it's not the best test for someone with kidney disease or decreased renal function. In such cases, a VQ scan may be performed instead. A VQ scan or a ventilation perfusion scan is a nuclear medicine study that uses radioactive isotopes to compare how the lungs are ventilating against how they're perfusing. If a patient has a PE where a blood clot is obstructing blood flow to parts of the lung, perfusion will be diminished while ventilation is maintained. It's this mismatch between ventilation and perfusion in a PE that the VQ scan will be able to illustrate. Still, the VQ scan is a far inferior test in comparison to a CTA when looking for a pulmonary embolism. So something we can do to avoid CTing every patient that comes in with chest pain and shortness of breath is a lab test called a D-dimer. It's a blood test that can help us rule patients out of a pulmonary embolism, meaning if the D-dimer comes back as negative, we can be pretty sure that the patient does not have a pulmonary embolism. D-dimer is a fibrin degradation product, meaning when the body breaks down blood clots, one of the things it produces is the D-dimer. The thing is, D-dimer can be elevated for lots of other reasons, such as being over the age of 50, being pregnant, having had a recent surgery, or due to cancers. So while it's not a perfect test, it can help us avoid unnecessary radiation exposure. If a D-dimer comes back elevated, that doesn't necessarily mean that the patient has a pulmonary embolism. But now we have to move forward with a CTA to make certain that the patient does not have a PE. So let's say we did find a PE, how do we treat it? Generally, the patient will be started on an anticoagulant to prevent further clots from forming, such as heparin, Lovenox, or warfarin. Surgical procedures include embolectomy, where the blood clot is physically removed from the pulmonary arteries. Let's watch one being done in real life.
We are on full cardiopulmonary bypass support. The next step is to apply the aortic cross clamp and achieve cardiac arrest. Here we're performing the pulmonary arteriotomy with a knife and then scissors, and you can already get a glimpse of the thrombus inside the main pulmonary artery. As it branches, you can see a grasper is used to remove the thrombus. This is a very large saddle embolus that originated likely from the patient's femoral and iliac vein. She had a fracture of her right lower extremity, was in a cast, and this was a likely source from the right leg. You can see the embolus is removed. A Fogarty catheter is used to clear any further clots, which none are found. Then at this point in time, we take the clamp off of the right superior pulmonary vein cannula. This allows us to perform retrograde pulmonary perfusion. It goes from the pulmonary veins back through the lungs and out the pulmonary artery, as you can see here. Small emboli and air are cleared, you can see in this portion of the video. Once we're satisfied that the pulmonary arteries have been cleared of debris, and we ventilate as well during this process, once we're satisfied with that, we'll stop the retrograde pulmonary vein perfusion. We'll inspect with the thoracoscope. You can see here the small branches of the pulmonary veins are cleared. The main trunk of the pulmonary artery is also clear. And we inspect the thrombus one more time. You can see this is a very well-formed thrombus.
Catheter-guided thrombolysis using a thrombolytic or a clot-busting medication such as TPA may be another option. You can see how on the left there is a decreased perfusion of blood flow, and on the right, flow is restored. If the patient for whatever reason has a higher tendency of developing DVTs, an IVC filter or an inferior vena cava filter may also be placed. These are also known as a Greenfield filter and are placed in the inferior vena cava to prevent blood clots from traveling up to the heart and the lungs. You may find that doctors sometimes ask really odd questions when patients come in with chest pain or shortness of breath. Questions like, have you traveled anywhere recently? Have you had any recent surgeries or prolonged hospitalizations? Do you take any birth control or are on any hormone replacement therapy? The reasons doctors ask these questions is because these are all risk factors for developing a pulmonary embolism. Other risk factors include previous DVT or pulmonary embolism, history of cancers or other clotting diseases, family history of DVT or PE, and tobacco use, especially for females. So when a doc asks these questions, make sure to document all of them. If the patient is currently on a blood thinner, make sure to document that as well. Because we don't want to be CTing or ordering dimers on everyone with chest pain and shortness of breath, doctors like to use a risk stratification tool called the PERC rule. If the patient is less than 50 years of age, is not tachycardic, has room air sats of greater than 95%, does not have unilateral leg swelling or hemoptysis, has not had a recent surgery or trauma, does not have a history of DVT or pulmonary embolism, and is not receiving any hormones, there is less than 2% chance of a pulmonary embolism and no further workup is needed. No CT scan and you don't even have to do a D-dimer. In addition to the PERC rule, other probability factors you might come across for PE includes the Wells criteria or the Geneva score. So that wraps up PE, let's move on to atrial fibrillation. Atrial fibrillation is when the top two chambers of the heart, the atria, beat in an irregular rhythm due to disorganized electrical currents. Instead of squeezing and relaxing, it spasms and quivers, which can cause patients to have palpitations, dizziness, lightheadedness, nausea, shortness of breath, fatigue, tachycardia, and chest pain. Normal resting heart rate is somewhere between 60 and 100 beats per minute, but in AFib, the atria can beat from 300 to 600 times a minute. The heart sort of has a safety mechanism where the AV node only lets a few of these signals get passed down to the ventricles, but this still results in a faster than normal heart rate, somewhere in the 100 to 170 times a minute. This is called AFib with RVR, where RVR stands for rapid ventricular response. Aside from the symptoms that AFib may cause, one of the dangers of AFib is that it could lead to strokes. Because the atria are quivering rather than squeezing, blood isn't really being pumped out. This can cause blood to pool in certain areas where it can begin to clot. If these clots were to get pumped out of the heart, one of the places they could become lodged is in the brain, which would be an example of an embolic stroke. One of the most common reasons that a patient will be on a blood thinner is because of AFib. Some patients may also receive what's called a Watchman device. Of all the blood clots that form within the heart, over 90% form in the left atrium in an area called the left atrial appendage. The Watchman device essentially blocks this area off so that blood clots won't be able to form. So we talked about how clots from the left side of the heart can lead to strokes. What about clots from the right side of the heart? Do these also cause strokes? Probably not. Remember that the right side of the heart pumps to the lungs, so if there was a blood clot in the right atrium that got pumped out, it would get lodged when it got to the lungs, causing a pulmonary embolism and not a stroke. Some patients are usually in a normal heart rhythm and will occasionally pop into AFib. This is called paroxysmal atrial fibrillation. For some patients, they're always in AFib, and that's just their usual baseline. Sometimes patients can feel themselves go in and out of these rhythms, and sometimes patients don't have any symptoms or complaints at all. It's not uncommon for these patients to come into the ED saying, "My primary told me I had an abnormal heart rhythm and to go to the ED." So how can we tell if the patient is in AFib? We do an EKG. The top is showing tracing of a normal EKG where the arrow is pointing at what's called a P wave. The P wave is when the atria contracts and is also considered to be the beginning of a normal heartbeat. Now let's look at the bottom EKG where the arrow is pointing. As you can see, there is no discernible P wave, it's just a bunch of random squiggly lines. These are fibrillatory waves caused by the atria spasming and quivering instead of contracting rhythmically. This is one of the characteristics of AFib on the EKG. AFib is described as being an irregularly irregular rhythm. If we look at just one heartbeat, there's no normal P wave, so this is considered an irregular rhythm. Remember how we said the AV node only allows some of the signals from the atria to pass onto the ventricles? This happens at irregular intervals as shown by the varying spacing between the heartbeats. This is why AFib is described as being an irregularly irregular rhythm. The irregular heartbeat is occurring at irregular intervals. In addition to the EKG, further workup in the ED will typically include a chest x-ray and lab testing to rule out other abnormalities. We will look at things like troponin, get a CMP to rule out electrolyte abnormalities, TSH to rule out thyroid dysfunction, and a coagulation study to evaluate the PT, PTT, and INR in order to rule out abnormal coagulopathies. Differential diagnosis for AFib will include other arrhythmias such as SVT, atrial flutter, or WPW. As far as treatment goes, it's common for patients with AFib to be tachycardic due to RVR. If they are maintaining their blood pressure, we focus first on lowering the heart rate before treating the abnormal rhythm. This is typically done with medications such as diltiazem, verapamil, or digoxin. Once we establish rate control, we can move on to fixing the rhythm. But there is something very important we have to do first. We have to make sure that clots haven't formed within the heart before we convert the patient back into sinus rhythm. Once sinus rhythm is restored, blood that was pooling in the atrial will be pumped out, and if there was a clot, we could potentially cause a stroke. So an echocardiogram has to be done before the patient is cardioverted. If the patient has been in AFib for more than 48 hours, or if they are not anticoagulated, there's a greater chance that the patient may have developed an intracardiac thrombus. Check out this blood clot in the left atrium. Imagine what could happen if this clot got pumped out of the heart. Who knows where it could end up? Restoring the heart back into sinus rhythm is called cardioversion. It can be done chemically or electrically. Chemical cardioversion will utilize medications such as flecainide, sotalol, or amiodarone. Electrical cardioversion is like the stuff you see on TV, where electricity is used to shock the heart back into a normal rhythm. It actually looks more like this in real life. If the patient wasn't on one before, they are usually then placed on a blood thinner to prevent blood clots from forming. Atrial fibrillation is caused by ectopic foci in the heart. These are cells that are capable of producing a heartbeat in case the SA node fails. Normally these ectopic foci are turned off, but when they erroneously fire, as in the case with AFib, they can prove to be problematic. If the patient persists to have AFib despite antiarrhythmic medications, a procedure called cardiac ablation may be performed by an electrophysiologist. This is when the cells at the ectopic foci are destroyed using heat or radiofrequency, preventing them from causing disorganized rhythms. And an electrophysiologist is a cardiologist who specializes in the electrical activity of the heart. So the next time you see an atrial fibrillation patient, be sure to document all of the patient's cardiac conditions, including previous history of atrial fibrillation, if the patient is currently anticoagulated, and if there was a clear time of onset. Sometimes the patients can feel themselves go into AFib, and again, ideally we want to treat these patients within 48 hours to reduce possibility of a clot and avoid strokes. Document if the patient has a cardiologist, and if they have had cardioversions in the past. Sometimes you can find details of previous cardioversions in Cerner, such as medications and dosages for chemical cardioversions and joules for electrical cardioversions. A few more tidbits about AFib. New onset AFib, which is a patient coming in and being diagnosed with AFib for the first time ever, is pretty much an automatic admission because the patient will require further cardiology workup, including an echocardiogram. A CHADS 2 score is an algorithm that estimates risk of a stroke in AFib patients. An holiday heart is a term used when patients go into an abnormal rhythm, including AFib, following increased alcohol consumption, typically around the holidays and family get-togethers, hence its name. So that's AFib. Let's move on to talking about pneumonia. Simply put, pneumonia is when there is an infection in the lungs. As the body fights off the infection, fluid tends to build up in the alveoli, which are the tiny air sacs where gas exchange occurs. Patients will generally complain of things like cough, shortness of breath, chest pain, and fever. Because these are pretty common and broad symptoms, the workup also tends to be pretty common and broad. A chest x-ray, which we obtain for pretty much every chest pain and shortness of breath patient, is actually one of the best ways to look for pneumonia. You can see in this example that there are infiltrates in the right middle lobe, indicating a right middle lobar pneumonia. Infiltrates is a fancy medical term for fluid that has passed through a filter of some kind, alveolar tissue in this case. And a real quick review on the anatomy of the lungs. The right lung has 3 lobes, upper, middle, and lower, and the left lung just has 2 lobes, the upper and the lower. While the chest x-ray is generally pretty good at catching pneumonias, smaller pneumonias may be missed on chest x-ray but caught on CT scans. If the patient has a productive cough, we can also obtain a sputum sample and send it for cultures. Although it will take some time for it to return, we will be able to tell if the infection is bacterial, viral, fungal, and its susceptibility to different medications. Looking at the petri dish on the right, you can see whatever grew out was susceptible to these medications, only kind of susceptible to these medications, and resistant to this medication. Most of the time, pneumonia is caused by a bacteria of some kind, so we empirically start the patient on antibiotics before the cultures come back. If the cultures come back showing resistance to the antibiotics the patient was started on, we will get the patient onto the appropriate antibiotics. In addition to antibiotics, patients may be put on a steroid such as prednisone, which reduces inflammation and can help patients with their breathing. HAP, or hospital-acquired pneumonia, refers to pneumonia in a patient who was admitted to the hospital recently. The thinking is that the patient picked up a bug of some kind while they were in the hospital, and pneumonia caused by these bugs tend to be tougher to treat as they have higher incidence of multi-drug resistance and worse prognosis. These patients will generally require readmission for IV antibiotics. Patients who are recently on a ventilator for surgery or during their hospitalizations can also develop what's called VAP, or ventilator-acquired pneumonia. VAP also has higher incidence of multi-drug resistance, worse prognosis, and will typically require IV antibiotics. HAP and VAP are in contrast to CAP, or community-acquired pneumonia. This is pneumonia where the patient has not been in the hospital recently and they just picked up something while they were at home or their work or somewhere around in the community away from sick people. Community-acquired pneumonia is typically treated as an outpatient with oral antibiotics, but sometimes patients don't get better and return to the ED with continuing or worsening symptoms. In these cases, a repeat X-ray will be obtained and compared to a prior one to see if the pneumonia has worsened. If the patient is not improving, they will have what's called failed outpatient therapy and will be admitted for IV antibiotics. This is why it's important to document recent hospitalizations and the patient's outpatient antibiotics course when applicable. Pneumonia, as common as it may be, can be very serious. It's actually among the top 10 causes of death in adults as it can progress to sepsis, respiratory failure, and other complications. Pneumonia is especially dangerous for children, elderly, and the immunocompromised. It's the leading cause of death in kids under the age of 5, and in patients with Alzheimer's or strokes who may have deficits such as dysphagia, aspiration pneumonia is an unfortunately common complication. That wraps up pneumonia. Let's talk about asthma. Asthma is when the airway, mostly the bronchi and the bronchioles, become inflamed and the smooth muscles contract, restricting airflow. This causes the patient to be short of breath and with wheezing and chest tightness. Patients will often also be tachypnic and tachycardic as they work harder to breathe and may also exhibit tripod breathing or accessory muscle breathing, which is called retractions. In addition to how fast the patient is breathing, you can see how they are recruiting their intercostal muscles in an attempt to get more air in and out of the lungs. One of the reasons why we intubate bad asthma exacerbation cases is because these patients will eventually tire themselves out physically. In the ED, workup will include a chest X-ray to rule out other causes, and depending on the patient and their story, EKG and/or troponin may be ordered as well. Sometimes the docs will also get a VBG or an ABG. VBG, or venous blood gas, and ABG, or arterial blood gas, are blood tests that can better assess how well the patient is oxygenating. Some of the differential may include anaphylaxis, aspiration, airway obstruction such as foreign body, pneumothorax, and pulmonary embolism. The best thing we can do for asthma patients is provide them with medications that will open the airways back up. Bronchodilators such as albuterol and Atrovent have different mechanisms of action and are usually given together in a combination called DuoNeb. It's administered via SVN, or small volume nebulizer, which aerosolizes the medication so that they can be better delivered to the lungs. You may have heard these treatments be referred in the ED as breathing treatments. In pediatric patients, kids will have a tendency to eat and ingest the medication rather than to breathe in and inhale the medication. In such cases, a spacer is used since these meds tend to work better when they go to the lungs and not the stomach. Another medication we can try is steroids such as Solumedrol and prednisone, which help by reducing inflammation of the airways. Some of the common asthma medications you might come across include albuterol, Proventil, Xopenex, Atrovent, Spiriva, and Singulair. Medrol dose pack, Solumedrol, prednisone, and prednisolone are examples of steroids. Important things to document for these patients will be medications and breathing treatments they may have tried at home, and if they're currently on any steroids. Doctors will often ask if they have been admitted or intubated in the past for their asthma exacerbation, and may also ask what usually works for them. Also document any potential triggers such as recent illnesses or environmental factors. COPD, or chronic obstructive pulmonary disease, is when inflammation and scarring of the airways lead to narrowing and breakdown of the bronchioles and alveoli. This causes nearly irreversible decrease in airflow and the ability to fully breathe out. You may also hear COPD being referred to as emphysema. Emphysema, more accurately, is a description of the alveoli walls breaking down, decreasing total alveolar surface area, and leaving behind large empty spaces. COPD falls under the umbrella of obstructive lung disease, which also includes asthma, bronchiectasis, and bronchitis. It's basically any respiratory disease where the airway becomes narrowed, obstructing airflow. What makes COPD different from asthma is that in COPD, the narrowing of the airways is pretty much permanent and irreversible. Similar to asthma, patients with COPD will have complaints of shortness of breath and wheezing. They will often have a long smoking history and may also report increased dyspnea on exertion. A chest X-ray will show hyperinflated lungs where the lungs appear to be darker and with increased vasculature markings. Another thing you see is that the diaphragm is lower and the heart appears narrower. In addition to the chest X-ray, additional workup may include EKG, troponin, and a BMP. A VBG or an ABG may also be done, and other lab studies such as CBC can tell us if the patient is anemic. Treatment will start with supplemental oxygen such as a nasal cannula or a non-rebreather mask, and in COPD patients, docs are generally okay with a slightly lower oxygen saturation, somewhere in the low 90s or even high 80s. Because COPD patients have irreversible lung damage, they may never be able to achieve 100% oxygen saturation or even saturation in the upper 90s. Pushing these patients towards such a goal may actually lead to complications such as hypercapnia, where excessive amounts of CO2 can build up in the blood. Similarly to asthma, we treat COPD patients with bronchodilators and steroids, and we can also try putting the patient on CPAP or BiPAP machine. While all of this is going on, it's very possible that the patient also has a lung infection such as pneumonia on top of their COPD exacerbation. That will be a total bummer, but in such cases we will also get them started on an antibiotic. Important things to document will be medications or breathing treatments the patient may have tried at home, if they're currently on any steroids, previous admissions or intubations for COPD exacerbation, what medication usually works for them, and if they're on any supplemental oxygenation at home. So that covers COPD, let's talk about pneumothorax. It's sometimes abbreviated as PTX and describes a collapsed lung. The lungs are covered by two linings. The inner lining is called the visceral pleura, and it tightly covers the lung, following the lung's fissures that separate the different lobes. The outer lining is called the parietal pleura, and it attaches to the inner surface of the thoracic cavity as well as lining the upper surface of the diaphragm. The visceral and parietal pleura are basically stuck together, only separated by a very small space called the pleural space or pleural cavity. The pleural space is filled with pleural fluid, which acts as a lubricant, allowing the visceral and the parietal pleura to slide across one another when the lung expands and contracts during inhalation and exhalation. The diaphragm, which sits below the lungs, is a dome-shaped muscle. When it contracts, it's pulled down and increases the volume of the thoracic cavity. Remember learning about Boyle's law in chemistry, where P1V1 equals P2V2? Since we increase the volume, pressure has to go down. So by increasing volume of the thoracic cavity, we create a negative pressure within the thoracic cavity. This is how inhalation works and how the lungs are able to draw in air. And here are a couple more illustrations of how this works. So pneumothorax literally means air in the thorax. When air gets into the pleural space, usually due to trauma, the visceral pleura separates away from the parietal pleura. The negative pressure generated by the thoracic cavity is no longer translated to the lungs and it collapses. From the animation earlier, it's like if I cut a hole on the side of the bottle. When I pull down on the diaphragm, all it's going to do is draw air in from the side and the lungs won't expand. The lung is incredibly dynamic and can actually shrink quite a bit. Pneumothorax patients will come in complaining of chest pain and shortness of breath. They will also be hypoxic or have low oxygen saturation. All of these symptoms make sense since the collapsed lung won't be able to expand and participate in gas exchange. One of the best ways to look for pneumothorax is with a chest x-ray. One of these is a normal chest x-ray and the other is showing a pneumothorax. Feel free to check them out and see if you can find a collapsed lung. The x-ray on the right is showing pneumothorax, and in this case it's in the right lung. Looking at the x-ray on the left, which is a normal x-ray, you can see how there are pretty even lung markings on both sides of the lung. If you look closely on the x-ray at the right, you can see the outline of the lung where it's collapsed. You can also see the empty space devoid of any lung markings, where you're just seeing the bony structures. In a large pneumothorax like this one, you may also see tracheal deviation where the trachea is shifted towards the side with less pressure. Tracheal deviation may also be evident during the physical exam. Small pneumothorax might be missed on the chest x-ray but seen on the CT. This is a different patient than the x-ray we saw earlier, but you can see how the lung has collapsed on the left side, and the empty space in the thoracic cavity shows up as a blank black space. Other things to consider in these patients will include aortic dissection, ACS, pericarditis, esophageal rupture or tear, heart failure, MI, PE, or a rib fracture. So now that we know how to look for a pneumothorax, let's talk about how we can treat them. We throw in what's called a chest tube or a thoracostomy tube. The tube gets hooked up to a water seal, which uses water as a one-way valve so that air or fluid that was removed from the pleural cavity won't go back in. Sometimes these also get hooked up to a vacuum source. The idea is that we're removing air from the pleural space, re-expanding the lung. After the chest tube has been placed, we will shoot a quick chest x-ray to confirm the placement. See if you can spot the side of the pneumothorax and identify the chest tube. For a small pneumothorax, a pigtail catheter may be used. These are much smaller than the large bore chest tubes seen in the previous examples. For example, the pigtail may be 14 French, whereas the chest tube may be 28 French or even bigger. They're called pigtail catheters because the catheter's end is curly like a pig's tail. As you advance the guide wire, the catheter straightens out. The curved end can help better navigate the catheter into various positions. This, by the way, is called a flutter valve. It's a one-way valve which allows air to be removed from the pleural cavity every time the patient breathes. Important thing to document for these patients will be the mechanism of an injury if applicable. Also feel free to throw in a chest tube procedure note if it's done by the ED doc, although this is becoming more rare as the trauma team is typically placing them. And that's all I got for heart and lung stuff that isn't CAD or ACS. Thanks for sticking me through the video.